calendar.
All right, let's give it one more minute or so. I see names still popping in. All right, let me just do a quick scroll here. 3, 3, 3, 3.
Not yet.
I'm not seeing enough board members even close.
Yeah.
All right.
There's Robert and Tony.
Okay.
I think you got enough now, Bill.
Okay, now I do. Yep, I got it. Okay, let's get started. Call this meeting to order. This is the Oregon Educators Benefits Board, this May 6th, 2025. Time is 1:01 p.m. Let me start by rolling down a roll call by voice here. Let me get my piece of paper out here. So that makes me here. Enrique. Come back to Enrique. Cheryl.
Here.
Thank you. Michelle. Come back to, do I have everybody? Yeah, everybody's listening. Okay. Sally.
Here.
You, Dr. Laura.
Here.
Thank you. Bonnie, saw you.
Here.
Tony.
Here.
Thank you. Susan Miller.
Here.
Misty. She was on this morning. Robert.
Sure.
Okay, rolling back down again for a second round. Enrique. Don't see Enrique. Michelle.
I'm here.
Thank you. And lastly, Misty. Don't see. So we're 2 down. Maybe they'll join in a bit. Okay, so that gives us enough to go. We officially call a quorum. I will bring up the minutes. Well, I'm not going to share them, but everybody should have gotten the minutes and the agenda from last month's meeting. I will take a comments section. Anybody have a comment about the minutes? If
Hello,
not,
Bill.
Yeah, go ahead.
Oh, there, my sound is working. I am here. Thank you.
Tony, or sorry, Enrique. That's you. All right. Okay, comments about the minutes? Anybody motion about the minutes?
I move that we accept the minutes of the April 1, 2025 meeting.
Bonnie moves. Do I have a second?
I second. This is Cheryl.
Cheryl seconds. Any additional comments? All right, all in favor, say aye.
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 Aye. Aye.
Okay. Anybody
Aye.
opposed? Anybody abstaining? Okay, that passes unanimously. So we will now transition to a review of the renewal decisions from last month and a show an approval of the final rates led by Kirsten and John from Mercer.
Great. Thanks, Bill. Good afternoon and welcome members of the OEBB board. Before we get started with the presentation today, we just wanted to thank all of our educators and assistants out there. Misty reminded us on the CL call this morning that it's Teacher Appreciation Week, and I should have realized that because I actually coordinated the teacher appreciation gifts for my son's 5th grade class, but I didn't realize it was statewide. So we just want to thank everybody for their time and contribution to education. We know it takes a lot of dedication to be there for our kids, so thank you so much. So today we're going to look back on the final decisions made for the upcoming 10/1/2025 plan year. We're going to start by walking through a summary of the program and benefit decisions made, and then turn our attention to review and approval of the final renewal increases. We'll end with a look forward towards our work together next year. Great. Next slide, please. In this first section, we're going to look at the benefit and program decisions that were made in the context of the board's balanced approach to achieving 3.4%. The balanced framework is an approach that we first proposed to the board and the board adopted back in March of 2023 for the 2024-25 renewal. And it reflects the different levers that are available to achieve 3.4%, but orders them according to the OEBB board's values and priorities. So the 4 pillars of the balanced framework, of course, the foundation is negotiation. And then we look at efficiencies, subsidies, and benefit changes last. Next slide, please. The primary renewal lever tools are negotiation and efficiency. So if you might recall last month when we made our final decisions, we had round 3 renewal rates in-house. And at the time, there was a gap of $60.2 million between where the renewal increase was coming in around 9% and our 3.4% statutory limit. So of that $60.2 million, we closed that gap using our balanced framework levers. So within that, $20.1 million was closed through negotiations and efficiency initiatives. So let's walk through together on this slide how that was accomplished. First, looking at negotiation highlights. For the MODA medical plans, there were 2 different things that were accomplished. First, MODA agreed to an administrative rate hold. So the fee they collect to administer the plans, they agreed to not increase that rate at all. That saved OEBB $2.4 million. And then of the margin built into the plan, which absorbs fluctuation in plan claims experience year to year, $3.2 million of that came from a reduction in margin. And then, of course, Kaiser made a premium concession on the fully insured premium rates. For closing the gap to $60.2 million, the premium concession was $2.6 million. Sapari reminded me they actually had a little bit of concession that they applied at the outset of round 1 also, making their total concession closer to $3.3 million. Plan efficiencies is the second aspect of our primary pillar of our negotiation and renewal strategy. This year, the total plan savings for efficiency initiatives is $11.9 million, and that comes from 2 different sources. One of those sources is the Garner High Quality Provider Finder tool, and that comes with a 700 individual and a 1,400 family annual cost share reimbursement maximum. That was worth $8.2 million in savings. And then also the EviCore site of care program for imaging and musculoskeletal services through MODA was worth an additional $1.1 million in savings. And then both Kaiser and MODA have a trend guarantee in place, requiring the plans to keep their claims experience limited to a 3.4% increase each year. That limit was exceeded, and so some money was due back to OEBB. Together, that was another $1.9 million for MODA and another $700K for Kaiser.
Kirsten, you want to take questions on the fly or wait?
Yeah, let's do it. Thanks for pointing that out. Enrique.
Thank you. Appreciate the information, but I'm struggling to, I know we're working on a communications plan on rolling out the costs and since we've seen rates going up, but when and I know this is just for the board, but I know people are listening to the board right now. I know school districts and others are listening to what we're discussing. And if I'm an outsider who's not privy to the information that we have, the question that I'll be asking is, well, if you have $11.9 million in savings and efficiencies and you total saves on 8.2 negotiations with carriers, then why do you have a $60 million gap? So maybe as a board, I think we need to be thoughtful, or as staff, how do we manage this communication? Because my members they're not going to care. Like, I'm still paying an increase, right? I'm not saying this is wrong, but I would like to be more thoughtful how we do it in the rollout, because I already getting emails from members who somehow got information before the board that things are going up, right? Significantly. So I think there's a missing link or a gap of communication that's going out without addressing the details.
Yeah, thanks,
Yeah,
Enrique. Go ahead, Ollie.
Oh, I was just going to say, I appreciate Enrique speaking up about that, because, it's no secret what the board has been deliberating over for the last 2 or 3 months. And I think that, well, obviously we'll talk a lot about the communications plan today. And, we've been out there talking with our advisory council over the last week and working through some of these decisions at really a kind of a micro level and getting people to understand how the board arrived there. And I think I couldn't agree with you more, Enrique. I mean, I think, how we communicate this with our members, how we do it, and show that decisions, for the board to meet its statutory obligation, decisions were needed to be made, and how difficult that decision, how difficult it was to arrive at the decisions from the board. And I think just being very transparent and encourage, public comments back to the board, encourage the lines of communication with staff, with our carriers, with the board, to really get through this time. It's not going to be easy, but we'll talk a lot more about that today and in the next OEBB board meeting, Enrique.
Thank you, appreciate that.
Yeah, thanks, Ollie. Let's go to the next slide. We'll talk more about your question too, Enrique. And I know the Mercer team also had a lot of reflection this month as well, just because these meetings are public and everything is discussed. Not all of the context is, can be provided, or all of the explanatory materials can be provided, maybe when they need to be. So it's just a challenge we're working through also.
Yeah, no, I'm good for the transparency, and I'm glad we're a public board, and I'm good for that. But what I'm saying is that we have people who are listening to these meetings, and they go back to my members and they're saying, hey, you're going to pay $700 on coverage on your plans, and they don't know that, they don't understand why, right? If you're going to be telling people your rates are going up, you should be telling members why. You should be telling your constituents the details and why and how we got there. We have a 3.4% cap. We have a $60 million gap, and we have healthcare that continues to be more expensive. You got to explain those details. You got to do your, fiduciary responsibility of teaching people why, not just say, well, OEBB is voted for increase $700 on your payment. That's not responsible. That's what I'm calling out.
Thanks, Enrique. We hear you about that. As you pointed out, of the $60.2 million gap in round 3, we just looked at the $20 million that was accomplished through the efficiency initiative and also negotiation. So as you pointed out, and as Ali discussed as well, because we are limited to a 3.4% renewal by statute. And as we discussed in April and also May, claims trend, and this is the reason for the high renewal increase this year, the claims trend, yeah, thanks, Cindy. Cindy's highlighting that they plan to to really focus on the why also in the member-facing communications. And these are things that we talked a lot about with the board in April and also in March. That claims experience driven by more visits that are more complicated, more conditions, higher unit prices, more access availability for appointments are all contributing to healthcare costs increasing at a higher rate than what was budgeted for last year. And so when the renewal increase comes in at 9% when the original budget was set at 3.4%, that creates the situation that we're in now, where we have to try to get the costs under control and bring them back to 3.4%. So that whole story about claims costs, as Cindy mentioned, is a really important aspect of the member communications. So we did make some benefit changes this year, and let's talk through those. The overall package of benefit changes includes some benefit reductions, and I know that's probably most interest to our members. They're worried about that, but the package of benefit changes also includes benefit enhancements, and we didn't want to lose sight of those. So let's walk through, and we're going to talk about these in a lot more detail throughout the day as well, putting these benefits in context and really making sure that we're looking at them with a full picture of everything else that's involved. But we'll do an overview of the benefit changes here. So for the benefit reductions, I know probably the most visible benefit change and the one you might be hearing most from your members about was that a deductible was added to Kaiser Plan 1, a $400 deductible. The out-of-pocket maximum was also increased for the Kaiser plans, but by $200, including Plan 1. Copay increases were made to most of the Kaiser and Moda plans. It was a nominal copay increase of $5. The Moda plans also saw a deductible and out-of-pocket maximum increase. And then we removed Moda Nurse Line because it was a redundant service and it helped save some administrative expense for the plan. And again, we'll talk about these in a lot more detail as we go through the day. On the benefit enhancement side, the family out-of-pocket maximum and the family deductibles now are 2 times the individual amount instead of 3 times. So for families with high collective costs, they may see a reduction in out-of-pocket expense. For the Kaiser family building benefit, within the current benefit limits, including the annual lifetime benefit limit, we are now covering artificial reproductive technology, so it's an additional service covered. The additional copay for bariatric surgery was eliminated for the Kaiser plans. And so now those plans just have the usual deductible and coinsurance. For the Moda and Kaiser HSA plans, for the supplemental imaging that's now recommended for breast cancer screening in women who are above average risk, so this is ultrasound and MRI, Moda and Kaiser will now be waiving the deductible for those services. For the Moda plans, we've added Garner, a high-quality provider selection tool. Garner comes with the 700 individual and 1,400 family incentive. And then on all Moda plans 1 through 7, we've added the site of care, which helps connect members with lower cost facilities, reducing their out-of-pocket expenses as well. All right, let's go to the next slide, please. This is a little bit of a sophisticated slide, but the idea here is really important. And when we talk about negotiation, what we're really talking about, and claim savings and benefit changes as well, there's 2 different buckets of money. One bucket of money is what the carriers are collecting in admin. The other bucket of money is for the claims expenses to pay for all of the services that our members are using. We negotiate those differently. So when we look at, and Enrique pointed this out, so for negotiation, the amount that we negotiated was $8.2 million between Moda and Kaiser. Maybe in the context of $60.2 million, that seems like a small amount. However, it's important to understand that of OEBB's $1 billion in premium, less than 10% of that is carrier admin. So we're calling that addressable spend. So the admin for Moda and Kaiser together is $68.7 million. So the fact that the carriers negotiated $8.2 million reduction from that $68.7 million addressable spend, that's an 11.9% savings rate. And this is in contrast to, let's look at the benefit changes. So yes, the amount, the dollar amount of benefit changes is larger than the amount of negotiation. It's 41.6 million. But the bucket of addressable spend, so all of the claims expenses for OEB members with Kaiser and MODA, is about $986 million. So more than 10 times larger than the admin bucket. This is not to say one is better than the other. It's just simply to illustrate that the starting amount for those buckets is different. So the dollar amount of what we can negotiate will be different. And so the benefit change savings as a percentage of the addressable spend was 4.2%. And so we're just looking at the idea of balance here in two different ways. Let's go to the next slide. So you may be wondering, where is subsidy in all of this discussion around achieving 3.4%? Because our balanced framework, one of the first things that we said this afternoon is our balanced framework is 4 pillars of negotiation, efficiency, subsidy, and benefit changes. Historically, last year and the year before, historically, when we have subsidized the rate, we've used RSR to buy down the premium increase. This year, we did not use RSR to buy down the premium increase, but that does not mean that there is no subsidy going on in the rates. So let's walk through these 4 pillars together. What do we mean when we talk about a subsidy? A subsidy is a decrease in premium that is not supported by an equivalent decrease in claims. What renewal tools are subsidy? So for example, reserve funds, such as the Rate Stabilization Reserve or the OEB Stabilization Fund, but also premium concessions and premium credits. So you might be connecting the dots to some earlier slides at this point. So what's the risk with subsidizing rates? Why don't we just do it as much as we have available? It's because subsidy used in one year must be added to the renewal increase in the following year. In fact, of the $60.2 million gap this year between round 3 and 3.4%, 6.4 million, so about 10% of that gap, was paying back RSR or making up for the RSR that was used last year to subsidize the Kaiser rates. But did we subsidize the 25-26 rates? We did by about 5.2 million, so a similar amount to last year. And that's coming from the trend guarantee credits plus the Kaiser premium concession. Because MODA is a minimum premium contract, the admin concession with MODA is different. So additional subsidization of the 25-26 rates, and this is something that we talked about as a board in March and April also. Additional subsidization beyond the 5.2 million already included in the rates increases the risk that we will be in the exact same position that we are in this year, next year. Just to put that in perspective, an additional $3.6 million in RSR would be equivalent to about another $5 copay increase to the MODA plans. So we discussed as a group in April and March, making sure that our overall amount of subsidy was less than 1%, because we are really thoughtful and very concerned about making sure that there are no benefit changes next year. Let's go to the next slide, please. Also, in March of 2023, along with the balanced framework for achieving 3.4%, we introduced to the board, and this came out of the board's values as communicated to Mercer. But we proposed to the board, and the board adopted these principles for approaching benefit changes. These principles recognize that we want benefit changes when we have to make them. And of course, they're not our priority lever. We want them to be equitable, so shared across all different kinds of utilizers within the plan. We want them to be sustainable, which means a couple different things. It means sustainable financially. It also means that we are achieving the triple aim. And we want our benefit changes to not get us out of competitive alignment with the market. So as we go through and talk about the benefit changes for the 25-26 plan year in more detail, we'll discuss how these benefit change principles are reflected in the final decisions, specifically how the benefit changes that were made helped the OEB board achieve the triple aim. If we could go to the next slide, please. Thank you. We have two slides, one for Kaiser and one for MODA, that show some historical information on the deductible and out-of-pocket maximum for these carriers. And we just want to clarify up front, and I'm sure I'll clarify again, the goal is not to minimize the impact of the benefit changes that were made for 25-26. We understand. The goal is to tell the full story of how the benefit changes fit into the bigger picture so that we have all of the information to accompany the benefit changes. So for Kaiser Permanente, and you'll notice that the earliest year on these graphs is 2014. Of course, the OEBB plans went into effect with Kaiser in 2008. This slide and the slide for MODA are just reflecting the benefit design information that was readily available to show in the board deck. For the 4 Kaiser plans on the left, we're looking at the amount of the deductible over time. So you'll notice that for Kaiser Plan 1, the deductible has been 0 since 2008, actually. And the 25-26 plan year is the first year that it has increased. For Kaiser Plan 2, there was a deductible adjustment in 2016. The deductible has remained unchanged since then. Plan 2B was new in 2021. The deductible remained $1,200 until the 10/1/25 plan year. And then Plan 3 had a small deductible adjustment of $100 in 2016, but in the 9 years since then has remained unchanged. On the right-hand side, we have the out-of-pocket maximums, and it's a similar story. The out-of-pocket maximums haven't changed since 2016 in general. And we highlight this because benefits are such a balance between the long-term financial sustainability of the plan and member affordability. And what happens over time if we do not increase the deductible and the out-of-pocket maximum in line with inflation? What happens is that additional cost pressure accrues to the plan because medical trend, our costs are increasing every year. So if member costs don't increase, that means that the plan's portion of costs have to increase even more. And this adds renewal pressure to the renewal increase. So it is important from a long-term financial sustainability perspective to periodically index the benefits to inflation. And this is something that we've discussed as a board last year as well. If we can look at the next slide. This is the same slide for MODA. Again, looking back to 2019, reflecting available data. Also in 2019, there was the combination of the Connexus and the Summit and Synergy plans. So there was a little bit of a portfolio mashup at that time period. Since 2019, the deductibles and the out-of-pocket maximums for the MODA plans have not increased either. This is the first year since 2019 that either one of those plan levers has been increased, despite the fact that we've had historically high levels of inflation over that same time period. Again, it's not to minimize the impact of the benefit changes on our members this fall. It's just simply to broaden the context that's surrounding the benefit changes. If we could go to the next slide, please. Thank you. Let's revisit some of our Kaiser benefit decisions in terms of our benefit change principles. The triple aim is protecting cost, quality, and access to care. So affordability to care, the cost and increasing the quality of care, and of course, increasing the access to care. So understanding that the deductible increase will be a cost share increase for some members. So we'll acknowledge that upfront. The board was able to protect access to primary care by increasing the office visit copay by $5. When we increase the deductible and out-of-pocket maximum, we are increasing the cost share for members who are our medium and high utilizers. When we also increase the office visit copay by a nominal amount, we strike a balance between equity. So now low utilizers are also sharing in the benefit changes, but with keeping the office visit copay increase to $5 only, we're preserving access to primary care. 3 of our benefit changes help our members by removing barriers to priority care. One of those is the cancer screening. So waiving the deductible for supplemental breast cancer screening for the HSA plans, removing the $500 additional copay for bariatric surgery, and now covering artificial reproductive technologies within the existing Kaiser family building benefit. We want to encourage efficient use of care. So emergency department care will now be subject to the usual deductible and coinsurance as opposed to being a fixed copay. And again, this is such a fine line to talk about, but it's important. The out-of-pocket maximum for the Kaiser plans is increasing $200. So remember, that's the first increase in 9 years for the Kaiser plans, much longer than that even for Kaiser Plan 1. So $200 spread over 9 years. It's a relatively small amount. Actually, it's lower than medical inflation if you do the amount, not to minimize the impact to our members. Also, to put a $200 out-of-pocket maximum increase in perspective for Plan 1, it's important to realize that the overall out-of-pocket maximum for Plan 1 is still only $1,700, which is the lowest of all of the plans in our portfolio. And for the members on Plan 1 still represents a significant value to them. Those members in the last plan year who were on Plan 1, there were about 400 members on Plan 1. Their plan expenses were about $33 million, or around $77,000 per person. So still being able to cap the cost share at $1,700 when the allowed amount was $77,000 is still a value. And then we've talked about reducing the family out-of-pocket maximum to be 2 times the individual. Let's go to the next slide and talk about our decisions in perspective for MODA. And the story here is very similar with one important exception, and that is because the nature of MODA being an open panel PPO plan, we have greater flexibility with MODA and what we do. The board was also able to add Garner, which does a couple really important things for our members, and you'll actually see Garner listed twice on this slide. For the MODA plans, first starting on the left, the office visit copays were increased, but by only $5. Again, the deductible is waived for imaging on the HSA plans for breast cancer screening. And then Garner also removes financial barriers to priority care because of the $700 individual incentive and the $1,400 family incentive. And those amounts were chosen very deliberately. The MODA Plan 1 deductible in the 24-25 plan year is $400. Deductibles for MODA increased by $300, making the new Plan 1 deductible $700. For members who use the Garner Provider Finder tool to find care, that entire first $700 will be reimbursed by the Garner incentive. Garner also encourages efficient use of care by telling members which providers have the highest quality and the lowest cost within the network. The site of care program does the same thing. And then MODA plans as well. So the MODA out-of-pocket maximums for an individual increased $900. So we want full transparency around that increase. The Garner incentive of $700 reduces that out-of-pocket maximum increase to an effective increase of $200. And we talked about that with Kaiser. So for the MODA plans going back to 2019, that's a 6-year time period. Dividing the $200 out-of-pocket maximum over 6 years, again, is a small amount each year. For the MODA plans also, the family out-of-pocket maximum and deductibles now are set to be 2 times the individual amount, anchored to the non-CCM amounts. Okay, well, there are no questions. I know that you guys must have some questions about Garner and helping to understand Garner better so you can help communicate the value of Garner to your members. So in the next section of the afternoon, John is going to talk to you more about Garner and more details and answer any questions that you have. And we'll just give John John might be having technical difficulties here. Otherwise, I can jump on and get started while we wait for him.
Hey, Kirsten,
Sorry, I'm here. Yep. Oh, go ahead.
I would just say just one additional thing. If you would like to send members to any of the staff, I mean, send them to me, send them to Cindy, Damien. I think, you know, we're here for you. I know this is very complex stuff to answer the why to what Enrique was raising. So I think you should always feel free to connect them with us, and we're here to support you. So just wanted to say that. Thanks.
Thanks, Ali, and good afternoon, board members. Thanks for joining the discussion, kind of a continued discussion from last month on Garner. So as a reminder, last month the board decided to move forward with Garner, so the implementation is underway. And you know, part of the discussion a little later is about the communications and how this will be rolled out to members and to entities as well. Our thought this month was to provide the board with some additional background around Garner in terms of the selection of top providers, access to top providers, the member experience, the financial incentive that Kirsten already discussed, and also member education and implementation. So some of this detail is already familiar to the SIAO members because they saw it last month because it was used as a basis for making their recommendation to the board. But we thought it might be better to kind of discuss it also more broadly with the board. As a reminder, Garner only applies to members enrolled in MOTA. And at its essence, Garner is an optional program that offers members an incentive to use high quality and cost-effective providers. And Garner calls these providers top providers. It's also important to remember that members who choose not to use a top provider receive the same MOTA benefit. So there's no penalty for not using Garner. You just don't receive the reimbursement of your out-of-pocket costs. The other thing, too, that's important for people to understand is really, or members to understand, is that Garner identifies top providers within the existing MOTA network. So inherently, top providers are MOTA network providers. I think that that's kind of an important thing for members to understand. And the incentive that we're talking about, the $700 individual and $1,400 for family, that is really the reimbursement of member out-of-pocket expenses. So these include deductibles, co-payments, and co-insurance. And this is, so if members who use top providers will have those out-of-pocket costs reimbursed up to the $700 per individual and $1,400 per family. And as Kirsten pointed out, and I just want to reemphasize, is these limits were purposely, set out to help mitigate the plan changes that were made to achieve the state mandated 3.4%. So in addition to the incentive, Garner provides greater transparency for members, to find high quality providers. And that's important because high quality providers are expected to yield better outcomes for members. I think the other thing to understand too is that, Garner isn't just about this renewal. To the extent that members use top providers, there's a real opportunity to bend trend going forward, which would help to reduce the risk of having to make plan design changes in the future. Next slide, please. So here, just wanted to kind of go through some of the due diligence that we went through in terms of the top provider selection process. So our clinicians reviewed the process that Garner uses to select top providers, and really have found it to be quite robust. In addition, a couple things to think about in terms of top providers. So top providers are, that it's based on a score. So the score involves both cost and quality, and then there's a threshold. So so if a provider has a cost and quality score above that threshold, they're considered a top provider. And then there's not a lot of more distinctions to be made once they're a top provider. In terms of differences between top providers that's not the purpose. It's really, are you a top provider or not a top provider? That's the key thought. The other thing to that members have the option to do, and Cheryl, I'll get to you once I get through the slide. The other thing is members can call up Garner and take a deeper dive. If there are quality metrics that are particularly important to them, the concierge team has the ability to take a deep dive into those quality metrics. I think the other thing to think about is also that top providers are a geographic concept as well. So it's really typically it's going to be providers that are local to that member or based on the geography that member has specified. One of the things that we found as part of the due diligence is that Garner could do more around including information around providers, and that would help members in their selection. And that's something that they're looking to work for. So, okay, let's start with Cheryl.
Thank you very much. I appreciate this information. I wonder if throughout the upcoming, as we apply this new program, are you continuing to evaluate these folks that have been selected as top providers so that we are ensuring that they stay at that level for our members?
Yeah, that's a great point. So that is something that's an ongoing evaluation that Garner does. So it's not static, it's ongoing. So that's an excellent question. Thank you. Any other questions, Cheryl? Enrique?
No, that helps me. Thank you.
Yeah, I've been thinking about this the last couple of weeks, and definitely over the weekend, and after receiving communication from members about this Garner platform, which again, I'm really surprised the members know about the Garner app, and then we are still getting information about this. Like, we got to tighten up our communication. I would like to encourage staff to work with the Gartner provider and create a video on how to use the app. Last time we were given very minimal time on how to use the app, especially when we're talking about a multi-million-dollar platform or in savings. And so I would encourage Ali to work with staff and encourage Gartner to create like a YouTube video or a link to your YouTube channel that says, hello, welcome to Gartner, in multiple languages. I have strong members who live in Hood River and Salem and Woodburn, Albany, who use Moda, and English is not the first language. And I was thinking about this because I got a fake text message from the DMV today. If you get it, they're not taking your car or your license away by polling, because we don't pay tolls. That's a different subject. My point is that it was in English and 2 different languages. So if we can do Spanish and Russian and Vietnamese for a starter, encourage Gartner to have that available, because they did talk about diversity on their presentation that we had last time. I know they made a commitment to Dr. Laura to have more bilingual information. So I hope that we continue to follow up on that, because they did that presentation and I voted for it because they were committed to multilingual diversity. So if we can work with Gartner on that, that'll be great. I appreciate that. And then you can send this the link to all the board members here, and then we can send it to all of our constituents. I have 42,000. I'm sure out of those 42,000, there's about 20,000 who use Moda, right? I'm just guessing, right? But I think that'll be helpful as we go through the summer and people kind of take a break from everyday task and they pay attention to their healthcare stuff before enrollment, before the fall.
Thanks for the suggestions, Enrique. Those are good ideas.
Next slide, please. So let's talk a little bit about top providers. So this is really the foundation of the Gartner program. So they're identified based on a performance score that we were talking about. This performance score has cost and quality components, and there are about 400. There are over 500 metrics that are rolled into this score, and it is based on a lot of data. So essentially, Garner has been able to get about 75% of the available claims data nationally, and then they use this data on, this provider data to kind of come up with the scores, and then they produce the scores, which are, driven by quality and by cost. And, the purpose here is really to identify providers in a local area that perform better than their peers. And the other part of this is that top provider designations are based on provider specialties, which makes sense, right? So you have, primary care, then you have, the common specialists, and then you have the subspecialists, and you have the behavioral health as well. So now we're going to take a deeper dive into, some of the quality things and some of the cost things that Garner looks at in developing their score. So if we can move to the next slide, we'll talk about some quality measures. When it comes to quality, Garner looks at, structure, process, and outcome measures to identify top providers. And we'll kind of help you understand what those things are. So in terms of structure, Garner looks at things as, is the physician appropriately licensed, and, make sure they don't have any major sanctions. In terms of process, they look at things like, does the provider apply appropriate standards of care? Like, do they use physical therapy before, going straight to low back surgery and things such as that? Another example of a process measure is really, do they use evidence-based guidelines? So good example of that is minimally invasive surgery. So, which is the laparoscopic surgery rather than open surgeries for appendectomies or gallbladders or things like that. So this, the use of those minimally invasive surgeries are great because it improves outcomes for one thing, and it also speeds the patient's recovery and return to work. Top providers are also selected because they do not use, they avoid unnecessary tests and treatment. So, you would see in terms of, prescribing patterns, these would be providers that are less likely to prescribe opioids and things like that. Then we'll move on to talking about outcomes. So when you talk about outcomes, you really have to adjust for differences in patient risk, though, because outcomes are driven by patient risk, among other things. So Garner adjusts their outcomes for risk and then looks at things like surgical revision rates and surgical complication rates. And then for the more serious procedures, it looks at things like mortality. So that kind of gives you a quick picture of those measures around quality that are factored in selecting top providers. Next slide. In addition to quality, Garner also looks at total costs of care when identifying top providers. And we'll kind of quickly go through some examples of the types of total cost of care that are looked at. So one is site of care. And again, you might be familiar that ambulatory facilities are less expensive than hospital outpatient departments. And so that's one of the things that they're looking at. And then when it comes to pharmacy utilization, are generic rather than brand names being prescribed where possible is kind of the question that they're looking at when they look at these metrics. And then the type or procedure of surgery. So we talked about the minimally invasive. So they're really just looking at, are minimally invasive procedures being used where possible? And then when it comes to medical utilization, the question is, are they avoiding unnecessary procedures and procedures that are, of uncertain value, like spinal fusions? And then the cost per service is that, that's another thing that they're looking at. And they're looking at the referral patterns. So does this physician tend to refer to cost-effective physicians and facilities? So these all get rolled up. So if you think of this, it's, all of these quality and these cost metrics, these 500, get rolled up into a score, and that determines whether the physician is a top provider or not. Now we're going to shift gears a little bit. Moving to the next slide is around member access. And as we'll see on the next slide, you know, the MOTA and Garner access standards are quite similar. And I think the other thing, as we go into this section, we want people to understand is that the access numbers being reviewed here are not, they're access to the top providers and not related, and that's related to getting the incentive. This is not access in general, right? Because the MOTA network that underlies, you know, the product here is not changing. So I think this is a kind of a key thought. So this is really access to top providers, not access to the Connexus network, which is not changing. I think the other thing to recognize, you know, as we dive into that, in rural and remote areas within Oregon, access to top providers, you know, within certain specialties is kind of reflective of the low number of providers in those areas in general. So like today, some members who are seeking subspecialty care are going to have to travel to receive care. A final note is really around virtual care, which has become more and more common since the pandemic. And, you know, for certain types of care and certain types of specialties, virtual visits might be available. And, you know, that would be helpful to the rural and people who live in rural and remote areas so they don't have to travel as far. So on the next slide, this compares the MOTA and the Garner access standards. And access is measured in time and minutes, and it's the time and minutes that it takes to reach a certain type of provider. So the thing is, so the access standards differ by provider type, as you can see on the left-hand side, you know, primary care, high volume specialists, and then subspecialists, and those are different categories. And then if you look at the columns, it's really the different geographic regions. And MOTA uses the CMS, the CMS approach to access standards, which has more cuts. As you can see, you have 5 different regions, and the Garner is kind of the more typical what we see in the commercial space, which is urban, suburban, and rural. So I think the key takeaway here is really how similar these access standards are. And when we're measuring access, as we'll see later, access is measured as a percentage of members who meet the access standard. And we'll see that when we get into the slides coming on. So I think the other thing to understand is really not meeting the access standard doesn't mean that members have no access to care. Rather, it means that they may need to travel to receive the optional incentive. And this is already true today. I mean, what's true today is people are already having to travel to receive care if they live in remote areas. And this is particularly true when it comes to subspecialty care, because in these remote areas, there's just not a large enough population to support subspecialty providers and, you know, support their practices. Let me pause. I haven't seen any questions. Oh, but I did see one just pop up. Sally?
Yeah, I mean, I guess my biggest concern here is that prior to Garner, you know, if you're rural or not rural, you are subject to, I suppose, the same costs, right? To some degree. But with Garner not really having a lot of access in the rural areas, it makes it much harder for people that do have I feel like it just creates a barrier, right? It's not as easy for them to access these essential providers and receive that additional benefit as people that are closer.
I think we need to wait and look at the access numbers, Sally, because we haven't looked at those access numbers yet. So
yeah, I mean, just how far they would potentially have to travel to get that. Mm-hmm. Or I guess sorry, I'm talking as I'm thinking, you know, too. I suppose that my hope is that some of these places do have virtual options, you know, if an in-person is not feasible, and then do those in-person options with these Garner providers also provide that same reimbursement. I'm just trying to, I guess,
Right.
ask
I mean, I think
fiscally is
I would say let's look at
equitable.
the access stuff and then see where and then pick up the conversation there. Does that sound good? Because
Yes.
again, these are just the standards. These are not
Yeah.
once you apply the standards.
Sure. Okay, thank you.
Okay, and then we'll get to that shortly. So then let's go to the next slide, which is really the next slide really illustrates the geographic distribution of the MOTA membership. And not surprisingly, you know, the membership is concentrated about 70% of it in the, you know, the Portland metro area, the Willamette Valley, and then, you know, the southern I-5 corridor. So just those three regions, you know, make up about 70%. And then the remainder is the coast, the central part, northeast, and southeast. So let's move to the next slide. And this is where we start looking at the access numbers. And as you can see, in the metro area, central, and the Willamette Valley, and again, this is just focusing on the specialists, and I'll speak to the primary care, because the primary care is actually better than this, as you would imagine. So let's talk about primary care first for all 7 regions. So pretty much for 6 out of the 7 regions, the only region where primary care has a bit of an issue is Southeast. And I don't think this is a surprise for anyone. But in terms of the primary care, the other regions, you know, are well covered. And when I say well covered, it's, you know, typically above 90%, mostly above 95%, and a lot of it at 99% for primary care. So what we're just looking at over the next couple slides, just to be super clear, are just the specialty and subspecialty care. And you can kind of see what the specialties we're looking at. So the high volume is really those common specialists that we're talking about, and then the subspecialists are really, you know, those that you typically will only find providers. You know, you're not going to find providers all over, you know, for certain of these specialties. And again, I think, you know, this is also the difference here is this is access to the top providers and the incentive, not access in general. So I think that, you know, just want to make sure that we're all looking at this in the same manner. And again, so I think we can kind of move on to the next slide. The next slide is just displaying Southern I-5, and you can see here, mostly very good, but again, just want to be clear, you know, gastroenterology, and if you look at that, and then if you look at endocrinology and rheumatology. And again, I think the other thing to remember here is that, you know, if you're seeing not a lot of top providers here, it's probably indicative that there aren't a lot of providers in these specialties in general in these areas. So I think that that's something, you know, to remember. But I do want to come back to Sally's question when we get to the next slide. So again, when we get to the next slide, which is more of these rural regions. So next slide, please. Thank you. So again, this is roughly 19% of the OEB MOTA population, and so this is coast, northeast, southeast Oregon, and as we talked about, you know, what we're seeing, the numbers we're seeing here are likely indicative of just the availability of providers in general in these areas. And I think that people who live in these areas, I think, are already traveling today to get care. So they might need to travel a little bit further to get a top provider and get the incentive. But again, they're, you know, based on some of the access, particularly in Southeast, that you know, these people are likely traveling already today. And by traveling a little further, they might, not only would they get the incentive, but also, they have the ability to expect a higher level of care as well. So again, you are not required to use Garner. If you choose to use Garner or a top provider, or if you choose not to use it, your benefit doesn't change. So Garner is an optional program, and that helps you find a quality provider and rewards you for using a top provider by reimbursing your out-of-pocket costs up to an annual limit. But I do want to come back, Sally, to your question. Now that we're looking at the results, particularly Southeast, I think that there are some clear challenges for specialty care in this area. Any additional thoughts that you wanted to add?
No, I mean, we don't, where we're at in Eugene, we don't have, necessarily as many people, right, in my district that are rural, but I am, I was just thinking about the people that are in the rural areas that just might not be able to as easily obtain that incentive as other people without traveling a little bit farther. I don't know if somebody from a rural area wants to speak on that. Really, it's just a concern, but I don't have personal experience with how that might be a barrier for somebody. Just bringing up that it might be.
Yeah, it's a good question. Cheryl?
Thank you. So I would actually be in what is qualified, if you go back a couple slides, a rural area and Hood River specifically. And I think that I don't know that I've had any complaints from our staff. I know we fit in that Metro Purple area, but if you go back a couple more slides, it indicated if one more slide, I guess, right there. And so your standards, time and minutes, and your rural county number 4. So Hood River County falls within number 4, which is a rural county. Slide 21, I think. But anyway, long story short, I don't think that, we have access to quite a bit of stuff in the Dalles, I believe. And then if you want to go, I a couple years back had a medical procedure that I chose to go to one of the providers that is covered by MODA, and it was just outside of the Portland area. And certainly I could have gone closer, but I made a decision based on outcome information that I was able to find from my research. And so I don't know that it's not necessarily available. I at least can tell you I've not had any of our team members talk about it not being available. So anyway, just my thoughts.
Sally?
Yeah, sorry, I remembered my question was, do we know if some of these essential providers offer virtual care? I'm assuming they do. And if so, if there are costs associated with that virtual care, if that counts for that reimbursement as well.
Yeah, so if they're offering virtual care and they're a top provider, it's reimbursable. And I think the other thing to know is care ordered by a top provider. So if the top provider sends you to, get an X-ray or to the lab, those services are also reimbursable under Garner, just to be clear.
Thank you.
Thank you. Bonnie?
Well, speaking of rural, traveling a little further isn't a problem unless it's winter and you have to go over Cabbage Hill and back. It's closed down a good portion of the time. So when you guys are saying traveling a little bit further, that could be like traveling from Hood River to Portland, which is, to me, not even a trip. we're talking hours plus driving obstacles. So I'm curious to see how it all shakes out in the Baker Creek, Gilliam, Grant, Harney Lake, Malheur, Morrow, Sherman, and I don't see Umatilla, but I know it's on there. But because Hermas, there's only I think 5-6 hospitals, and they're hundreds of miles apart. So there's a big travel difference.
Yeah, I think that what this tells us is also this is something we're gonna have to monitor on an ongoing basis. That this is not a one and done thing, but something that we'll have to continually look into.
And then will they go across state lines? Because I have a hospital here where I live. There's a hospital 30 miles south in Pendleton, and there's several specialists in hospitals 30 miles away in Washington. So
Mhm.
how far does the travel extend, or what's the specialist range? Or there's lots of questions I have. I'm done. I
I
started.
I guess the other question though, Bonnie, is how much are people traveling today, and if they will need to travel more? I think that's and that's really a hard thing to get your finger on, but I think that
Right.
that's the question. Any other questions or comments or discussion?
John, Robert had a question in the chat.
Oh, sorry about that.
Oh, it's all right.
I think we'd need to check in with Garner because I don't know how often they update their top provider pool. So Robert, we can get back to you on that. So I don't know if it'd be within a plan year or not. That's a great question.
John, Robert's question was the top one. What percentage of MODA primary care providers are Garner top providers?
Yeah, so that just came in this morning. It won't be in the presentation. I believe it's in around 21%.
Sorry, I'm driving. That's why I had to chat. The reason I ask is if one of our members only uses primary care and they don't actually have much specialty care, but they do have pharmaceuticals,
Yep.
then only 20% of them are going to be able to take advantage of the Garner deductible maximum out of pocket benefit then, right?
I don't think you can make that conclusion, right? Because the thing is, it depends on the percentage that are using. It's a slightly different question. What percentage of, yeah. So I think we'd have to kind of look at that, but I think that's a good question.
Yeah, it comes down to, and we've talked about this a little bit too, Robert, and what John is pointing out is that there's maybe a 20% overlap between the PCP 360 network and the Garner top provider network. We need to look at who the members are actually going to see as the missing piece. But then also, Robert, there will be a contingent of members who are not connected or attached to their primary care provider. And that's where we need to look at the access percentages instead. And so the access percentages are for primary care, depending on the area, close to 100%. And so that's saying that within that certain driving distance limit, there are many Garner top providers available from members to choose from. It's only going to be if a member is set on maintaining their existing provider relationship. And we know for some people that will be true, at least this year. Maybe that's something we can work on over time. For them, you're right. But for everybody else, there's plenty of access to Garner top providers.
But it's just, I ask those because I have a concern that we might oversell the Garner deductible benefit then.
We'll have to see how it plays out over time, Robert. I think you're right. I mean, it depends on what members decide to do.
Yeah, the Garner, it's an important distinction, Robert, that you're bringing up. The Garner, so the deductible and coinsurance services are different than the primary care copay services. all are eligible for reimbursement with the Garner incentive if a member uses a Garner top provider. So let's say a member is primarily using primary care or specialty care, so they're having a copay-based service, in which case the copays are eligible for reimbursement if they, and also as John pointed out, imaging and labs ordered by that top provider are eligible for reimbursement. But you're right, maybe a member through office visit, copays only, isn't going to use up the whole $700. Where the $700, $1,400 really comes into play is for members who have deductible coinsurance services. So any sort of procedure, outpatient surgery, inpatient stay, for those services, maybe members don't generally have a pre-existing relationship. Maybe it's a referral. So there's a new opportunity there to connect members with the app to make sure that that new provider is a Garner top provider. And so that more expensive, costly service is eligible for the incentive. That's where we're going to make sure members are using all of the available $700, $1,400 Garner incentive.
Robert, does that answer your question? Or at least a start to it? We can always come back. Sally, did you want to? Oh, go ahead, Bill.
I said Robert said he was driving, so he might be difficult to respond.
Okay, yeah. So let's move to Sally then.
Yes, okay. And I suppose I should have asked this at our last OEB meeting, but is Garner a permanent fixture in MODA now, or was this partnership kind of intended to be a temporary solution?
I think the intent would be that this would be going forward for the OEB plans.
Yeah, so it's an annual renewal, so yeah, decisions can be made depending on how it goes. But yeah, I think MODA said that they were looking seriously at Garner as part of the PEB RFP, and Providence was the previous year as well. So I think PEB is considering Garner as well. So there will be a lot of communications with both OEB and PEB members this summer.
Okay,
Yes.
yeah, I was just curious if, renewal comes around next year and that we'll have the opportunity to really take a deep dive into the efficacy and outcomes of all of this.
Ultimately, board decision, right? Misty?
Hi there. I just wanted to kind of mirror a lot of the same sentiments that I'm hearing as an overarching theme, and the component of rural geography versus urban. I think that how we choose to inform our members about how this program works, you're going to have a barrier in the rural region. Already they're going to think that it's an equitable service for them based on the concept that there's just fewer healthcare options over here. So it's really important on how you roll out that this isn't intended to create another situation like Kaiser geographically limits your access to things, right? So I think that'll be an important component. And I think next year I'm eager to really look at the data that we can collect after using this and seeing how it is used in different regions and the savings associated with that and things like that. Because I think that we need to be really informed going forward and listen to the feedback of the members after this next year of using it. So thanks.
That makes a lot of sense. Thanks. Yeah, just looking at Dr. Laura's comment. Okay, so I think let's move one more slide and another slide, and then we're going to shift gears a little bit into the member experience. And again, Garner is designed to be easy to use for members. So we'll kind of walk through, how does this work? So step one is, helping you find that top provider. So members can use the app, or they can contact concierge support to identify top provider. And essentially, just by searching for the top provider, and it essentially tags that top provider for that member in the Garner system. So this is how they're able to do the adjudication in step 3. So the step 1 is finding that provider. Step 2 is going to visit the top provider and paying the applicable copays or cost shares, if it's coinsurance or deductible or what have you. And as we talked about, the services that are ordered by the top provider are also reimbursable. And then step 3, it's the same process that occurs today. So the provider submits the claim to MODA, MODA processes the claim, and then MODA sends a claims file over to Garner. And then in step 4, Garner uses that the claims information from MODA to automatically reimburse the member. And then the member can either receive a check, or they can set up direct deposit within the app if that's their preferred way of reimbursement. So again, designed to be easy to use from a member perspective. And also, I think the other thing is that if people don't want to use the app or not comfortable with the app, there's a concierge service. And the concierge service offers, the same process that you'd follow in the app. And then if they want to take a deeper dive into any of the quality measures around a certain provider, they are able to do that. And then the next slide is around the financial incentive. And again, we talked about this a little bit earlier. And there's, $700 for individual, $1,400 for family. And again, those levels were set, designed to really help offset some of the changes that were made in the plan design around the deductibles and the out-of-pocket maxes. And as a reminder, those plan design changes were made to meet that 3.4% cap. And, if you have the services that require it, use of the full incentive more than covers the deductible and covers most of the out-of-pocket maximum change. So again, but that's going to be driven by, as Kirsten pointed out, by the mix of services that you use. And if you use services that require deductible or not, or just copays and things like that. So there is a possibility, based on the member utilization, that they could actually be better off, by using Garner providers, top providers. Tony?
Thanks. Yeah, interesting evolution. I'm curious, just from a practical standpoint, I heard you say that the exchange of information between the member and Garner. Can you just talk a little bit about that exchange of information? Is that an electronic communication? I heard you say that it also has a direct deposit as a mechanism for receiving that incentive.
Yeah, so if we could go back one slide, I think then we can better address your question. So what the member is doing in the app is using the app to select and tag the top providers in the app. And then a lot of this is transparent to the member, right? So what they need to do is select the top provider and use the top provider. And all this other stuff is happening in the background. Just want to be clear about that. They're not having to do anything. MODA is sending the claims file to Garner. Garner is reimbursing the member. That is all transparent to the member. What the member is doing is essentially finding the top provider and using the top provider, and the rest of it is occurring in the background. Does that help, Tony?
It does. So I'm hearing you say that the member does not have to take any action themselves to receive the benefit.
Well, what they do, remember, they have to select a top provider and use a top provider. That's what the member has to do.
But once that's done, the rest of this happens in the background.
Correct. Yeah.
Okay. What happens if they coincidentally select a preferred provider, but they don't do it using the tool?
That is excellent question. Then there's no way for Garner to know. So the thing is, there would not be a reimbursement. But the thing is that there's a possibility to kind of get ahead of that if they figure it out and call in the concierge line and see if they can accommodate.
And I popped online just to confirm that, Garner would be is compelled to follow all HIPAA guidelines. It's not.
Yeah, they're subject to HIPAA like everyone else. Yep,
Okay.
Exactly.
Thank you.
Yep, thanks. Good questions. If there are no further questions, let's jump 2 slides down and wrap it up. And this is really, again, as we talked about at the beginning of this section, the implementation is already underway. And member education, and this goes back to Enrique's point, member of education is critical to the successful implementation of Garner. So I'm going to go through a couple of member-focused efforts. And the first one is a little bit like Enrique was talking about, but frankly, I like Enrique's idea better about a video. So the thing is that there was, part of this was an on-demand webinar, and this could be a video too, to help people understand how Garner works. And then the next, the other thing too that's occurring in terms of communications is the integration of Garner into kind of all of MODA's materials, be it member brochures, be it handbooks, be it their microsite, that has to permeate the MODA materials as well. So that's the second piece. And then the third piece is that the OEBB staff is already building custom communications around Garner that will be included as part of the regular open enrollment communications. So this is already, we understand that this isn't easy to get your head around. And I really appreciate the effort that the board has made and the questions today to get your head around this. It is not easy to get your head around this, but I think, with good communication, this can be explained and it would benefit members. In addition to outreach to members, there's also outreach to the entities, and this is already starting to occur this month. So as part of their regular rollout of the renewals, MODA will be meeting with 90 plus entities in the month of May. And, Garner will be obviously an important topic in those conversations. In addition, Garner will be explained at the open enrollment benefit fairs by MODA. And then Garner has also agreed to attend some of those benefit fairs in person themselves. So that will be another venue for both member and entity education. The other piece too is that Garner and MODA are working together to build a train the trainer materials, and these train the trainer materials will better position entities to educate members and respond to their questions. So that closes out the Garner section. And again, I do really want to thank the board, for investing the time to learn more about this, because we assume you're going to get questions about it, and we want to prepare you for those questions that will be coming. So any further inquiries before we move on to the next section?
Tony?
Yeah, this again may be an off the wall question, but when an individual has a cafeteria, I don't know if I'm using the right language here, but like health equity account to be able to set aside dollars for reimbursement for healthcare purposes, is the ability to request reimbursement, it would seem to me, through that health equity account compromised if the individual has also received reimbursement through Garner. In other words, you can't get paid twice.
Yeah, you can't get paid twice. And the thing is, so I think you're referring to health savings accounts, Tony, that are associated with high deductible health plans. Is that correct?
Or HRAs, John. Yeah.
Well, I mean, either one. The thing is that you can only get reimbursed once. And the thing is also, if it is an HDHP, a high deductible health plan, in that situation, you need to fulfill the IRS requirements around the deductible before Garner can kick in. So there are some nuances around high deductible health plans and Garner, but it really relates to making sure, and that deductible for high deductible health plans for this year is $1,650. So essentially, once that $1,650 is met, then you can receive reimbursement through Garner for any additional deductible above the $1,650 and then the cost sharing.
And it does not, the entities are still able to maintain current HRA and HSA accounts. The Garner HRA can be stacked with both of those. So there's no loss to existing entity contributions.
Sally?
Yes, I'm sorry. With the FSA, so flexible spending account, how is that going to work?
And I think that was my question as well.
Oh, so yeah, so the
Yeah, so
FSA,
not
because there's so many,
HSA.
yeah, not
FSA.
HSA. So you're talking about FSAs.
Yeah.
Yeah, and again, if you're going to have, it's something that we probably need to confirm exactly how that would work. But again, we need to kind of just understand exactly. So your thinking is, if I have a copay and I submit it to the FSA and to the reimbursement, what happens?
Well, yeah, because for at least with Pacific Source with the FSA,
Mhm.
people can request a debit card. So you get the preloaded
Right.
debit card that you can pay medical bills with, co-pays, so that's kind of the form of how people pay for most of the things. They swipe that for their copay at the doctor's office or pay their medical bills with that. So if I, pretend it's me, I have MODA and I go do the essential, preferred provider, essential provider, whatever we're calling it. And I go see one of them and there is an associated cost, but that triggers Garner, right? But I've used my FSA card to pay for that. And then Garner gives me a reimbursement. I mean, that seems like unmanageable to police if you cannot do both. We can educate employees, like if you have an FSA, if that's not allowed. If you have an FSA, you can't use it to pay for your medical bills. You have to use your debit card or credit card, and then you can get reimbursed by Garner. But it seems.
Yeah, no, that's a good question, and we'll get some clarity and get back to you on that. That's a good one. Any other questions? And
We're
again,
gonna need to move on to the renewal communications by Cindy. And I'm gonna
Bill, we
change the
just need
schedule
to
around for this
do,
afternoon, so I'll give you the schedule change after Cindy's done.
Bill, I think we need to do the renewal vote by the board before we move
Oh.
on from this
Sorry.
stack. Just one more thing. Yeah.
I didn't see an action item there. Okay. Where are we doing that? Is that a slide for that?
Yeah, it is. If you go, I'm going to see if I can pull it up here too and let you know a slide number, slide 30. And it should be very quick. We just need formal approval of formal approval of the final renewal increases. So when all is said and done and the benefit changes are applied and the negotiation credits are given and the efficiency and site of care credits are given, then this is where all of the renewal increases land. So the overall renewal increase is 3.39%. And it depends on exactly what carrier and line of business. The renewal increases will vary. 3.56 for Moda Medical, rate hold for vision across the board, all carriers, 2.84% for Delta Dental. The Kaiser overall renewal is 3.36%. The Kaiser Medical renewal is 3.4%. Kaiser Dental 3.06, vision a rate hold. Willamette Dental is at 2.51% VSP rate hold for an overall renewal of 3.39%. In prior years, we've gone through all of the actual rates together, but last year there was discussion and a decision made that approving the renewal increase was good enough.
All right, board, study that for just a second and I'll take a motion. Then we'll have some comments. Motion can be to approve the rates as displayed. Tony?
I think I can make the motion. Just one last question before I do the 3.39. Is that to the 100th decimal below? That's below that cap?
3.4, we're just under
Right,
it.
it's below the 3.4% cap, and this is based on an enrollment as of December of 2024.
So I move that we approve the renewal increases as presented.
Okay, motion on the table from
I'll
Tony.
second that, Bill.
Okay, I didn't see who popped up
It was
there.
it was
Sorry.
Misty.
The Misty. Okay, Misty seconds. All right, any last discussions? If not, I'm going to roll call this vote, if you don't mind. All right, I don't see any discussions. Enrique?
I'm good. Thank you.
Cheryl?
Yes, I'm sorry. Yes, I approve.
yeah.
Yes. Sorry.
I took it as that. Got it. Cheryl?
Yes.
Michelle?
Yes.
Sally?
Yes.
Dr. Laura?
Yes.
Bonnie?
Yes.
Tony?
Yes.
Susan?
Yes.
Misty?
Yes.
Robert?
Aye.
And chair votes for. Motion carries. Rates approved as presented for the renewal. Michelle?
I just have a question about like, what if we were not able to come to an agreement? What would happen if we were deadlocked?
We'd have meetings every night until June 29th.
The chair would vote. Yeah.
Yeah, because we have 11. So technically chair breaks tiebreakers
Yeah.
in certain formats.
Got it. Thank you.
Yep.
All right. Was that it, Michelle? Oh, there we go. Thank you. All right. We need to, let me just say what's going to happen here. We're going to do 15 minutes for Cindy to do renewal communications. Take a 10-minute break. We're going to then have David from the Standard do his presentation a couple minutes earlier than planned, but roll next, followed by Ali. And then we'll push the other things, maybe legislative update if we have time, but we'll push the other two off till next month. So let's roll into Cindy and then we'll take a short break.
Hi, everyone. Cindy Bowman. Nice to see you all. Rose, you can actually go to the next slide. Thanks. Communications are going to be a big deal this year. I think that's been demonstrated in the first part of this meeting. We are in the process of developing a strategy. So I just want to say right up front, we don't have all the details in this. I'm just going to give you a high level-ish summary kind of what we have planned and what we're considering. And then next board meeting in June, we will have a full plan laid out for you. As you can imagine, it's a lot of work going into open enrollment. So I'll go through initially kind of what our plans are for maybe some things we're considering, and then also there's our regular communications, and I'll run through those with you too. So we are going to prepare members for the fact that this is a required open enrollment. Again, last year we had the non-mandatory passive open enrollment, and kind of had hoped we could do that 2 years in a row, and plans changed because we had some benefit changes in Garner and a need to really focus on communications and making sure people get into the enrollment system. So we do plan to educate members about our plan changes, and Enrique, we definitely are going to cover what the current health insurance landscape is and how that affects. We will go into much more detail on that than we have in prior years when it's just been kind of a normal year. And then kind of what our approach is for the 2025-26 renewal. So if you, I'm just going to make a pitch right now. If any of you have specific things that you want to make sure that we cover or suggestions for how we cover it, please send them to me or Sarah Berthume. And the two of us, we're working with Erin Ward and her Mercer staff and also the rest of our communications team, but we're really interested in your feedback and interested in knowing what you think will help members and also the entities understand, what's going on going forward. So we are also planning to expand our communications. A lot of our communications in prior years have been very focused strictly on our members, and we are going to expand that. And Rose, if you could move to the next slide, we'll talk a little bit about that. It is a required open enrollment. This is kind of the timeline for that. It's August 15th to September. Next slide, please, Rose. Okay, so these are the things we're considering. These are things that we're expanding on. We haven't made final decisions on any of this, but are interested in your feedback. So we believe very strongly that we should create some talking points that have consistent messages so that we can use those messages throughout our entire communications plan. So in how we message things on our websites, to our open enrollment guide, to newsletters, to whatever we put out there. So we are going to be working on those talking points. Along those lines, we're hoping to create a leader admin toolkit, if you will, that will include things like a timeline, FAQs, and those talking points we just mentioned. That will go to entities, and we're also developing that for our benefits staff because they get the phone calls and they get the questions. And so we're even looking at maybe creating a script with different scenarios so that they can easily answer members' questions without forwarding it to somebody else. And so we're looking at that. Again, none of this is really fleshed out quite yet. So there will be more to come on that. And if you have feedback, definitely send it. We are going to do, we always do an open enrollment webinar that includes our carriers and other vendor partners. This year, we're considering doing a pre-open enrollment webinar. Linda Fries, who's our benefits manager, had suggested kind of a series of educational webinars for members on specific topics. Garner will definitely be one where we can deep dive into details and really help members understand how it works and how to use it and all of that, what the benefits are of it. There are other topics. We initially thought of doing those in separate little smaller webinars and are kind of considering putting those all into one larger webinar and then posting links to different places on our website. So more to come on that, but that's one of the things that we're thinking about. Garner does have several resources available to us now. We do want to customize those so they are specifically relate to how it's going to work with OEB and for OEB members and entities. So they did send us some things that are a good place for us to start, and we're going to kind of work from there and update specifically so they're customized for OEB. And we'll do some targeted emails about Garner. We'll do them during open enrollment, the start of the plan year. So Typically, we do a lot of stuff around open enrollment and don't necessarily, I mean, we have some informational that goes out when the plan year starts. But this time we'll probably say, hey, remember your Garner benefit, and really put that front and center with our members. Cheryl.
Do you have any idea, thank you, when the earliest pieces of information will start coming out, your earliest communications? Do you have estimates, please?
So we have insurance committees meet on May 15th. And so we are preparing for that presentation. That's, if you're not familiar with the insurance committees, those are the administrators, and we go through plans, the various plans and the benefits and all of that, so they can select their plans for the upcoming plan year. We are going to focus on Garner and benefit changes during that. So that'll be our initial push. We won't have all of the detailed communications, but we are putting together, the webinar is already scheduled, and we have a renewal summary that you will see soon. I think it's in its final draft, and we're just reviewing that, so you'll get access to that, and so will the entities prior to that, the insurance committee meetings. So what I just want to say, we recognize that it's people are going to be anxious to get information in their hands, and we want to work quickly to do that, but we also want to make sure that it's accurate and we have all the information, and we try to address questions before they come to us. So some of it may take a little longer, but we're working very hard to get information out as quickly as we can. So.
Thank you.
Mm-hmm. Okay, so those are some of just the new things that we're considering. If you have other suggestions, please send them to me or Sarah Berthume. Next slide, please, Rose. And finally, these are the things that we typically send out every year. So we have the insurance committee materials that I was just mentioning. We do an email. We have the webinars, the renewal summary, all of that. We're working on the benefit comparison charts. Even as we speak, that's one of the very first things we do. That has already been out to our vendor partners. They've looked at it, they've sent their edits, and we're finalizing the design of that. So that should be completed soon. Rates, I think we are finalizing those, and we'll put together a rate document and add links to our web pages. Benefits guide, we're as soon as we get the benefits comparison charts done, we move into updating the benefits guide. And this year it's going to be probably a little more work because there are more benefit changes. And also we want to make sure that we capture information about Garner in that. Just as an aside, I don't think I mentioned it on the last slide. We may well pull out Garner information and create its very own guide so that people have something that they can walk through without all of the other enrollment information. We have we'll be updating the websites, obviously. We also have the benefit education resources that we've had for a couple of years that Mercer helped us design a couple of years ago, Explore Your Benefits, and also the online plan comparison tool. So people can go in and pick and choose this plan and compare it to that plan. Every year, members get a personalized letter that references the plans that are available in their school district or entity, local government, whatever it might be. We do save the date postcards, all of that, getting ready for the open enrollment webinar. That is specifically for admins. So that won't go out to members, but that helps admins get ready for open enrollment. Then we have the open enrollment webinar for members. And we do a day one email that goes out that says, here, remember to do this. It has all the links that people are going to need to access information. And then throughout open enrollment, we do reminders, emails to get in and enroll. Remember it's required. Remember it's required. Remember it's required. Go in and do it. Go in and do it. And then once they do, we send them a confirmation email and say, hey, you're enrolled. So good job. And then we have some post-open enrollment emails or letters that go out that if they don't have a saved email in their My OEB account, then we'll send a letter out to them following enrollment. So those are the typical ones that go out. I think that might be the last slide. Do we have any questions about those though? Sorry, I know I'm kind of rushing through it. I know we have a short period of time and I know we're going to go into depth next month, but if you have questions, Bill, it looked like maybe you did.
No, I just checking. All good. All right, so back to the change in schedule. Let's do a short break from 2:45 now to 2:55. And David from the Standard, are you online? You good to go at 2:55?
Yeah, that works for me.
All right, we'll start with the Standard at 2:55. So 10-minute, no, now 9.5-minute break. See you at all at 2:55. All right, everybody, let's get back into session. I don't know if it was last month or 2 months ago. I think it was 2 months ago, maybe. We had to push out the standard because we ran out of time. This is their coming back to present what they were originally going to present, maybe updated. And our presenter is David from the Standard. Go ahead, David.
Great. Thanks, thanks, Bill. Everybody, I'm David Scarce with the Standard. For those of you who do not know me, I am the executive contact for OEBB's life and disability programs. Rose, go ahead and jump to the next slide, please. So today I'm just going to be giving you a quick refresher on the Standard's life and disability offerings, as well as an update on our digital and technology roadmap, our portal experience enhancements, and lastly, some updates on our evidence of insurability experiences. And I know that I've been given 20 minutes to do this, and I promise I will be done quicker than that. So try to keep this moving forward. So quickly, just to level set, the Standards offerings, we partner with OEBB, and we're providing basic life insurance, basic dependent life insurance, basic and optional accidental death and dismemberment, known as AD&D, optional life insurance, short-term disability insurance, and long-term disability insurance. And what's available to the members is really determined by each entity and their insurance committees. Next slide, please. So to go along with the insurance policies that we have, so we have some value-added services as well. And when members are enrolled in life insurance, so whether that's basic life insurance or optional, there's some extra little programs that we provide at no cost. The first is our travel assistance program. And travel assistance is a service that's available at no charge to members and their immediate family members when they're traveling more than 100 miles from home. So that's domestically or internationally. Members can use travel assistance to help plan a trip, to get some basic or emergency services when they're traveling. If I'm traveling internationally and I lose my passport, what do? Well, I can reach out to travel assistance. If I am traveling and I run out of a prescription and I don't know where to get it filled, I can reach out to travel assistance. They also have some translation services available, as well as help with emergency medical evacuations. Next slide, please. The other service that we have available for those that are enrolled in life insurance is our Life Services Toolkit. And this provides services to both members and their beneficiaries should the member pass away. So on the member side, there's some financial planning tools that are available. And the one I always like to point out is the estate planning tool, because that comes with a will template that allows members to create a legally binding will at no cost. So, I can't tell you how many times I've gone to benefit fairs, talked with folks and asked them, hey, do you have a will? And 50% of the time they're saying, no, I don't have a will. And I always redirect them over to here to hey, you have access to this Life Services Toolkit. You can create a will at no cost. And most folks don't even know that that's available. So these are just some services that are out there that we want to make sure and remind people that are available to them right now because they're enrolled in the life insurance. And then should the member pass away, there are some beneficiary services available, such as grief counseling, financial planning tools, legal services, things like that. Next slide, please. We also have a program called Because Nice Matters, and it's kind of a unique program where we empower our frontline employees to give thoughts of kindness to claimants or beneficiaries who are facing challenging situations. A good example of that might be, a life analyst is working with a member who has lost the child. And so with a partnership that we have with Harry and David, that life analyst, sends that member a flower basket, something, kind gesture to say, hey, we're thinking about you. We understand this is a difficult time, and we want to know that we are here to help you. Next slide, please. We also help members in making sound enrollment decisions, and we do that by offering our decision support tool. And this is, it's a mobile-friendly device, a program that fits any screen, whether it's you're working on your laptop, you're working on your phone, whatever. It provides informative videos that gives information about benefits in plain language. It provides self-paced tours and benefit claim stories to provide some real-life examples that illustrate the value of the benefits. And it offers calculators to help members estimate what's the right level of coverage for them to meet their needs. And the other nice part about this is that we also have a link right within this that goes to my OEB. So once someone goes through this and says, okay, I think I know what I want to do now, they can hit enroll now, and it takes them right into my OEB so they can enroll in their life and disability benefits. Next slide, please. We also have a microsite that we created for OEB where we provide all of the information about all the life and disability plans that the standard offers to OEB. So we have coverage highlight documents, we have frequently asked questions documents, we have certificates of insurance. There's also links there to our decision support tool, any forms that members might need, and it's all available right here on this site. And so this is a great resource site for both members and entities that need to support their members to be able to get information about the life and disability plans. Next slide. All right, so let's talk about some of the enhancements and innovations we have at the standard. Next slide, please. So as you can see, we got a lot going on here when it comes to our technology and digital experiences. And don't worry, I'm not going to go through this line by line. But it's just really to kind of show that we've got a lot going on. Not all of this pertains to OEB, but it really kind of shows the magnitude of what we've got going on in 2025 and 2026 when it comes to our digital and technology forecast. We've already delivered some exciting enhancements to our employer and employee portals. We're fully embracing the efficiencies that can be gained by artificial intelligence. We're continuing to build out our data exchange by launching single sign-on capabilities with some of our benefit administration partners. We're continuing our momentum in our data delivery to include new API partnerships, which are those cloud-based real-time interfaces. And for the remainder of 2025 and 2026, we're continuing to build out products and services that will be supported by our portals, such as our Workplace Possibilities program, our 80 AAA services, and most recently, our paid family medical leave benefits. Next slide, please. I think this is pretty exciting. The standards entered into a strategic partnership with Evolution IQ to apply their AI-generated guidance platform to our disability claims. And so this partnership underscores the standard's commitment to leveraging innovative technology to amplify our already best-in-class claimant experience. And so we're using Evolution IQ's cutting edge technology to identify what claims need attention based on claim activity, like, hey, these documents were received, or the timing of what the doctor is saying, or the diagnosis. And so while this service provides guidance, it still places standards examiners and analysts in the decision-making authority, but it really gives them tools to help be more efficient and really put the right resources on those claims. So it provides some streamlined duration guidance to ensure that we got the right resources to the assigned claims. It also helps identify claims for advanced payments. So we have recently moved into this world of advanced payments where we're identifying claims like pregnancies or simple surgeries or routine surgeries where there's a very defined recovery period. And we're making the decision to approve the claim, and we're paying them all the benefits up front. So normally under short-term disability, the payments are paid on a weekly basis. With advanced payment, we know that this duration is 6 weeks for this individual. And so we go ahead and pay them 6 weeks up front. The claim is open and closed and done. And so the member gets all their benefits. It's very efficient. It's a real nice added benefit that they don't have to wait week to week to get the benefit payments. We're also using Evolution IQ to quickly identify candidates for our Workplace Possibilities program. It identifies these potential high opportunity candidates for return to work. So rather than relying on manual reports that we run, we use this technology and modeling and artificial intelligence to identify these high quality candidates for return to work. and it really makes sure that we're putting the right resources on the right claims to get these folks back to work, or make accommodations. Maybe they're only going back to work on a part-time basis, but we're identifying those folks and working with them to get them back to work. And lastly, using this Evolution IQ, it really promotes a smoother transition between short-term disability and long-term disability claims. The tool provides supportive alerts and claim management tools to help the examiners prepare the claim for whether it's going to be somebody who's returning to work, or for somebody who is maxing out their short-term disability claim and moving into long-term disability. So it's pretty exciting, and we're really excited about the possibilities that this AI platform has for us when it comes to disability claim management. Next slide, please. We've also introduced two-way texting. And so this was a service that we launched back in January. And it's really unique to the industry because we allow members to communicate directly with live agents. We don't use bots. We don't use artificial intelligence. Members simply, instead of calling the 800 number that we have for OEB, they can just text that number. And so they can get questions answered to, routine questions or support through the claim process, using that same number that they would normally call to talk to a contact center representative or file their claim. And if the conversation gets too complex because they're working with a live agent, the live agent can say, this might be a little more complex than we should be handling over text. How about I give you a call right now? And if the member's not ready to take a call right now, they can schedule a call at a later time to kind of go through the specific questions in more detail that you can't really cover in text. The service is currently supporting English and Spanish, but we're going to be adding additional languages later this year. Next slide, please. Our newest enhancement is e-payments. So beginning July 1st, disability claimants are going to have more options available to them when it comes to getting their benefits. Currently, somebody who's getting short-term disability, they can only receive a paper check. That's the only option they had available to them. But coming July 1st, they're going to be able to have direct deposit, Zelle, or a paper check. And then with our long-term disability folks, they already had direct deposit available to them. So we're going to be adding Zelle to that platform as well. And then we're starting off with our disability claims, and we're looking to add other products in 2026, such as life insurance, for example. Next slide, please. And go ahead and jump one more. There we go. Great. So we've expanded and enhanced our employee portal. So it used to be that telephonic intake or paper intake were really the methods for folks to be able to submit those claims. There was some online capability available, but it wasn't very robust. Well, this new employee portal is very robust. It allows employees to file their claims online and upload documents. And there's just some screenshots here of kind of what it looks like. And so once they've filed that claim and uploaded that document, it says, hey, here are your next steps. And why don't you go ahead and jump to the next slide, please. And the other nice part about this is the employee can go in here at any time and see kind of where they are in the process of their claim. So if they see that there's some outstanding information that's missing, they can help gather that information to get it submitted to the standard. They can also sign up for text alerts. And so that's a program where anytime there's a significant change in the status of their claim, a text goes out. So whether new information was received that we're reviewing to make a decision has been made, they're going to receive a text alerting them to the change in status of the claim. Next slide, please. And one more. So our employer portal has undergone a significant refresh. We used to have a portal called Abonese. And now we have a real web-based portal, employer portal, and it's now completely comprehensive and self-serving. So we've developed it to easily, release future enhancements, and we've also developed it to have some pretty robust reporting functionalities that are not available or that were not available previously. Next slide, please. So now employers have dashboards where they can quickly see what they have, any open tasks that are out there for the employer to complete. It provides them with quick claim summaries. The employers can then complete that task online, upload any required documents, and make sure that they've done their part nice and efficiently online through the employer portal. Next slide, please. The entities can also research claim information using claim numbers and claim names. But the real benefit now is that they can filter this information so that they are only getting the relevant information. So if they want to create a report and they only want to look at pending claims, they can do that. Whereas previously they would create it, they would run a status report and it would include all claims. Well, now they have the ability to pick and choose and create the reports that they want. Next slide, please. And so the customizable reporting is really the big added benefit of the new portal. Now employer entities can go in and create their own reports. They can select the data points that they want. They can remove columns, add columns. They can save these reports for quick recall and be able to do them whenever they want. Like, hey, I want to know, I need to run an employer FICA report every week. And so now I can just set up a report and I can go in and run that specific report for a specific group population of employees every week. Next slide. So once they've created this report, they can now save it as a favorite. And that means that, I know that I'm going to run this report every month, every week, every 6 months, and I don't have to recreate the wheel every time I do it. It also allows you to view the information that you've created in that custom report, as well as downloading it to a spreadsheet format so you can slice and dice and do whatever you want with it to upload to your side of the, to the entity systems. Next slide, please. And so now, lastly, I just wanted to talk about what's going on in our world of evidence of insurability. So with evidence of insurability, anytime a member is applying for coverage that's in excess of the guarantee issue level, or they are, for example, applying a late enrollment for a long-term disability, evidence of insurability is required. So they have to go in, submit an application, and a lot of times in the current environment, there's a link within MyOEB. Sometimes the members select it, sometimes they don't. There's nothing that reminds them that they need to submit this evidence of insurability. So we have a new program called Connected EOI, and it's our premier evidence of insurability offering. And kind of the magic, I guess you could say, behind it is, rather than the employee having to remember to do things, we actually are setting up the outreaches to the employee. And so once it's set up, the standard receives an inbound file that says, hey, here are all the members that selected coverage amounts that require evidence of insurability. How much are they requesting? Basic information like the employee's phone number, address, email, and then we actually send out an email invitation to the member to say, okay, you have selected coverage that requires evidence of insurability. Simply click on this link, you go right into our server, and you submit your evidence of insurability right then and there. We also have auto adjudication associated with this. So if the person hasn't, if they fill out their application online, they hit submit, and everything qualifies, they get an immediate approval. If there is additional information that's required or additional review that's needed, the member gets a notification that says, thank you, we've received your evidence of insurability application. We're now going to review it. Our current environment with the Connected EOI, we're averaging about a 70% auto adjudication rate, and we expect that to kind of continue to tick up. We're hoping to get around 80%. Next slide, please. And this slide just shows a real detailed process flow of Connected EOI, how we get the information from the employer. We reach out to the employee. We provide the follow-up to the employee, to the member. Those qualifying conditions get an immediate approval. Other conditions or other applications are going to need some additional review from medical underwriting. The turnaround time is significantly faster than the current platform. Decisions then are reported back to the employer on a daily file feed that updates in the employer's system. And while this is really great, it's not something we have in place today with OEB, but we're trying to put it in place with TELUS Health. So it's not something we can put in place with the MyOEB platform you currently have, but we have been working with TELUS to have this as an enhancement once TELUS Health rolls out. We were hoping it was going to be in 2025. It sounds like now it's going to be pushed out to 2026, but this is going to be a feature that's going to go live, and it's going to give that immediate decision. It's going to make sure that, in today's environment, there's a lot of manual handoffs where premium deductions can get missed. And so these types of things will go away with this new evidence of insurability process flow. And I think that's all I have to go through today. My last slide is thank you so much for your time. If you have any questions, I'm happy to answer them. But that's kind of what's going on in the exciting world of life and disability insurance. I know you're all in awe, I can tell.
All right. Board members, questions for David? Sally?
I don't have any questions, but I just want to say I appreciate all these add-ons. They seem like they're going to be very user-friendly and help a lot on the administrative level.
Yes, absolutely. I agree completely. And, this is just the beginning. We're really going into a pretty significant technology roadmap upgrade. And so, like I showed, there's a lot going on in 2025, continuing to go on to 2026. We've already got things planned for 27. So this is just kind of an ongoing process of updates and enhancements.
Anything else from board members, staff? All right, I'll say thanks, David, for coming back. Sorry we delayed you for a month or two there, but we got you in.
No worries. I appreciate the time. Thanks, everybody.
All right, thank you. We're going to jump ahead again to director's update and put Ollie in the hot seat.
Yeah, thanks, Bill. I just have a couple of quick notes. The June board meeting will be our last before reconvening in September. So just a reminder, there's no July or August board meetings as we get out and start talking to members about open enrollment. As you know, June will be our chair, Bill Gruff's last meeting with OEB, and having served 8 years on the board, at this June board meeting, we'll be conducting the election of officers and elect our next board chair and vice chair. So as referenced in the board bylaws, the board will elect or reaffirm the chair and vice chair each year, no later than the month of August, which we don't have a meeting in August, so we'll do in June. Terms of office will be structured such that after serving as vice chair, the vice chair will move into the office of the chair. So that means Enrique Ferrara as vice chair will move into the OEB board chair at the end of the June meeting, and we will be looking to elect a new vice chair. So also as referenced in the representation among officers section of the bylaws, the representation among officers will be structured such that the chair and vice chair officers are filled by representatives from different stakeholder constituencies. The board will elect the chair and vice chair from a slate of eligible candidates. So since Enrique is in a labor seat, eligible candidates must be from a slate of management, health policy, or district board representatives. That slate would include Cheryl Berger, Andrea Lara, Bonnie Luisi, Tony Mann, and Misty Wharton. If anyone from this list has interest in the vice chair position, please let me know in the next couple of weeks. Can answer any questions or give you more information. I'm happy to discuss the role of the vice chair and what that really requires. So I think that's it. Bill, is there any questions about that?
Were any questions for Ali on where our status is as we close out this fiscal year? From anybody? Margaret, are you still hanging in there?
I am still here, Bill.
Well, let's just give you your 15 minutes of fame for this fine day.
Yeah, thank you. Sounds good. And it may not take 15 minutes, although I'm happy to talk for as long as board members have questions. Good afternoon, members of the board. I am going to quickly just give an overview of what is a board attachment 5 in your packet. It's a status update on the innovation work group, and it's a little bit of an interesting update because the innovation work group actually meets next week. They have been on hiatus for a while now, so we're reconvening next week. So this status update is almost like a sneak preview for you to kind of understand what they're going to be tackling and what the plan is moving forward. And certainly invite any questions or anything you want to ask during this presentation. I know we have some newer board members who probably aren't as familiar with the work that the Innovation Work Group has done to date. But to kind of just give the high level, as I mentioned, the work group has been on a bit of a hiatus. Since last spring, Tom Silderbo had been the chair of the work group for some time after Jeff Brown, who had previously been the chair since the work group started in 2018. We took a hiatus last spring and are now reconvening. The Innovation Work Group is a joint subcommittee with OEB and PEB members. Right now, we have 2 members of OEB participating in the work group. Big thanks to Sally Duerfelt. Next week will be her first meeting representing OEB on the work group. And then also Robert Young. And then likewise, 2 members from PEB, Kimberly Hendricks and Sean Parkman. And the innovation work group, I shared a little bit of information in the report in terms of in the appendix as kind of a background section, just as a refresher. The work group under Senate Bill 1067, which passed in 2017, the bill directed OEB and PEB to create a joint executive committee and develop a plan to combine functions of the 2 boards. And so this executive committee met for a period of time and moved to fulfill this directive by creating a joint innovation work group, which would be charged with working collaboratively to identify innovative solutions to achieve sustainable, cost-contained benefit programs. And this work group launched in 2018. Things have evolved over time. Back in 2018, CIAO existed as an OEB-only work group. So the Innovation Work Group was kind of looked at as the first joint subcommittee of both OEB and PEB. Now, of course, CIAO has evolved and also functions as a joint convening body for the 2 boards. So we are, in the course of developing the work plans, doing some careful work to strategize and ensure that the scope doesn't overlap, that Innovation Work Group sort of has its body of work and CIAO has its particular areas of focus. Looking ahead for next week's meeting, a lot of the work of the Innovation Work Group is really focused on looking at sustainable cost models for the benefits programs. So next week, we are going to look at updated data on performance of the PEB and OEB hospital payment cap that was established in Senate Bill 1067. The Innovation Work Group previously has looked at the first and second year's performance of that cap. In those 2 years, analysis found that the cap saved OEB and PEB combined approximately in the range of about $160 million over the first 2 years. We are going to be looking at 2022 and 2023 data on the hospital payment cap to see where our payments are falling and ensure that, that the goal of the cap in keeping payments at that 200% of Medicare or better level is being met. We'll also look at some additional data analysis on carrier payments across service areas, benchmarked to Medicare. So essentially, where are OEB and PEB payments falling as a percentage of Medicare in various service categories? So both of these topics at next week meetings are going to be informational. We'll have some discussion, questions, identify areas of follow-up. We are not going to be seeking any decisions or recommendations from the Innovation Work Group. The work group In general, its role is to make recommendations to the OEB and PEB boards, similar to CIAO. No specific action items at next week's meeting, but those will certainly come in future meetings. Looking ahead at the draft work plan, we do expect the work group to will not convene in the summer. Historically, our subcommittees have identified kind of more in-depth work to take on over the summer months and haven't held their standing public meetings. We'll reconvene in September. Look at our tentative work plan is to look at progress on our value-based payment arrangements. We're looking ahead at having meetings every other month for this particular work group, so that then later in the fall, we would look at our carrier performance on cost trend performance guarantees, looking ahead at 26. This notes some work plan areas under development, including, I want to flag, I think an important area for the innovation work group next year will be reviewing and monitoring performance of Garner. I know that, based on the earlier conversation today, that'll certainly be a particular area where we're going to want to spend a lot of focus. And I do want to note, as we think about that analysis and that monitoring, one thing that may be a challenger consideration will be timing of that. As we get into next winter and the board begins to consider benefit plan renewals for the next plan year, we will only have probably about 3 to 4 months of actual plan year experience under our belt, and even less of that when you consider claims run out. So in terms of the data and utilization available, we're going to really try to strategize to do our best so that we have as much data as possible to help inform decisions as early as possible. Recognizing that by the time renewal decisions need to be made in April, we'll only be about 6 months into that plan year, so may not have as much data as we'd like. But that will be important ongoing work. I do want to note that the innovation workgroup meetings are public. We have the 2 members of OEB and 2 members of PEB identified that sit on the work group, but any board members are welcome to attend. Next week's meeting is 2 to 4 on Wednesday. So if you are curious and interested in sitting in to listen to the conversation and ask questions about any of the data that's being reviewed, that is absolutely an opportunity available to any board member. We certainly welcome that. And I'll pause there for any questions.
Opening the floor to the board. Questions on the innovation work group, IWG. I have a basic question that just popped in my head. Innovation work group, does it work with Mercer as well, or is this just staff and the board members?
No, we work with Mercer as well. So there's quite a bit of actuarial work done, and that is Mercer provides that support to the work group.
This is Dr. Lara. Can somebody share the invitation or where I can find the invitation for next week meeting, please?
Yes, absolutely. Yes, we'll make sure that is sent out to the full board, and you can put it as tentative or definite on your calendars, or don't feel obligated to attend if your schedule is busy. But as I noted, we certainly welcome your attendance.
There's no food and coffee served at the IWG, just so you know.
Alas, no, it's tricky to do that at virtual meetings.
Sad. Okay, anything else? If not, let me just give a quick 60-second roll through of what we did at the CIAO meeting this morning. We had just a couple items on the agenda, short meeting. We began by discussing the behavioral health vendor partners and going through the roll-up of those things, vendor management program, and the upcoming evaluations at Q3, Q4, how they're going to integrate with Garner to see how that all rolls out. And then vendor partner programs will be evaluated programs looking for equity and minimum language support by the end of 2026, and then reviewing outcomes for the following year as some of the programs are new. and updated the target participation rates chart from what we saw last time to just show a modest increase in what we have now in membership participation. And that will be done through a communication strategy, the standard stuff of direct via output, but better apps and electronic control information on how to help members find information on how to get to the sites for help, behavioral health type stuff, and then a new offering of train the trainer sessions for our entities to become local health champions for wellness via benefit administrators and HR people. That was then followed. Oh, questions? I'm blocking my own view of everything. Okay. We went into pharmacy innovations and trends after that on our standard annual health research update. Went through the FDA drug approval process, how we go through phase 1, phase 2, and phase 3 trials, and then go through the application process, followed by drug labeling, FDA review, and then final decisions by the FDA. A couple chains of new drug things. There's a lot of innovation going on in pain management. A couple new drugs coming out, one in particular, non-addictive work being done on pain management, and these would be in short-term pain management, as in post-surgery or post-trauma type situations where you had an injury. Course of day being like a 14-day course kind of things. These are drugs that are in the final testing stages and out for certain types of usage. And they are in for longer term medical. And then additional pain medications in the pipeline we went through. Some of them are quite expensive. Quite expensive. Some of them are intravenous. Some of them are stem cell. A lot of them involve back pain, and especially for herniated discs kind of things. So those are being tried, and there's one of them that's being tried around the world, but not here in the US yet. And we went into then new biologics for anti-inflammatory work, which includes the various types of anti-inflammatory inhibitors and modulators that are being worked on and still being done, T-cell blocks and various other types of antibodies. These are new drugs, again, coming out. Some of them have been around for a while, but all of them are expensive kind of things, and seeing where they go. Just paying attention to those kind of things. Lastly is a big one that you see on TV all the time, which is psoriasis treatments. 7.5 million adults having psoriasis, with 20 to 30% of those patients being severe, meaning greater than 10% of their skin coverage being affected by psoriasis. Lots of new therapies coming out. And let's see, probably 10, 12, well, 4 categories with 12 drugs being tested. Some of them are in the final phase testing, ranging from anywhere from basically 15K a year up to 130K a year for these types of things, most of them averaging in the upper 10, so between 75 and 100K a year. So just knowing that that's in the works. That was 2019 data, so it's still quite old, but a lot of those drugs are now out, like Humira, and biosimilars have been around now for a few years, but some biosimilars that are coming that'll reduce those costs. We talked about MS treatments. There's some new stuff. Ocrevus is now out for the last couple years. There's a subcutaneous version for Ocrevus now, starting in last year, so you don't need a full IV for it. And there's some new biosimilars coming out that are in final test that appear to be quite effective and will hopefully reduce some of the cost. Lastly, we spent a lot of time on gene therapy drugs. These are quite complicated, various types of things where you have in vivo type gene therapy where you use a virus, you alter a virus to inject some gene modifications. And then the other one is where you extract some cells and modify the patient's cells and then re-inject them back into the patient. These would be things for like sickle cell kind of work or blood diseases, CAR T cell therapy, treat certain blood cancers like leukemia and lymphoma. These are things in the works. They are running anywhere from 500,000 a year up to 3 million per year for this type of treatment. Things again that are very interesting, and we'll see how the outcomes and the final tests go and how that rolls through the medical system. Lots of drugs in the pipeline for gene and cell therapy. By that I mean like 20, more than 20 of them on the way. Again, studies being done are for rare diseases and cancer are the primary use, but some for neurological, which would be like Alzheimer's and things of that nature. And then HIV treatments, these are kind of in a kind of long-term, very difficult. There's no vaccine approach coming that is working, but there are things to limit the effects of HIV and more research being done on that. The final one, which is the one that I had asked about, is the weight management drugs known as GLP-1s and various other types. They're now coming out next year with pills instead of injections, although the pill stuff is still anticipated to be somewhere just under $1,000 a month. And those will still be some more testing going on with that, but we will have a lot more drugs being released in the next year or two involving weight reduction. And primarily, I think the ones that'll probably be most popular will be the pill-based ones. And we just started thinking about what the Seattle's work frame network for next year is going to be and how we're going to continue the work of Seattle and looking at all these things. Questions? I know that was a quick run through, but a lot of good stuff talked about in CL on pharmaceuticals today. That was quite interesting. Seeing no hands, we'll flip over for legislative update. Glenn, are you still with us?
Yep, I'm here.
All right, you're up on the screen.
Okay, thanks, Bill. As everyone's probably knows, we've actually passed the really first milestone in the legislature. We've gone through the first chamber where bills have to be approved by a policy committee and then either moved on to the floor for a vote, or they move to committees where they can kind of live till near the end of the session, such as Ways and Means and Rules. At PEB OEB, we still have 69 bills that we're following or watching. 17 of those are what we call as priority 2, which means they would have a financial impact. We've got 31 as a priority 3, and then the remainder are, which means they don't have an impact on PEB and OEB, at least financially. And then the rest we will just be monitoring to see if they get changed. The next stop really is right now the second chambers will be looking at bills, the committees that were passed in the first chamber. They will have a deadline of really May 23rd to get it out of the second chamber. Some bills that, we're still watching. Rose, if you could go to the next page. Thank you. House Bill 3212, which is a bill to really add more requirements to what are called PBMs, which are pharmacy benefit manufacturers, which would add costs to our MOTA plans, is currently in rules. From what we've heard, rumor-wise, that this bill's really not going to move out of there, so we're not too concerned about that. Senate Bill 535, which is the bill to require really across the board coverage of fertility benefits, plus to not allow benefit plans such as OEB, which has a benefit maximum, to have any type of maximums or limitations, and really has a significant financial impact. That actually, well, this is a mistake. It's actually in Ways and Means right now. Bills that are in Ways and Means really wouldn't move until after the May 14th revenue forecast. Ways and Means is waiting for that forecast to determine how much money the state will have on hand. Those are really the two ones, the P2s that are still alive that we're watching. There are some others, Rose, if you can go to the next slide, that we're watching. Other priority 2 bills. Yeah, these also either have an impact or may not, but we're watching those for right now. The two I just mentioned were just really the most significant. So I just wanted to kind of open it up, whether folks had questions on any of the bills I went over or any of the bills on the list here.
Open floor for the board. Any questions for Glenn? Enrique?
Enrique.
Yes, thank you, Glenn. So I know we've been discussing on the board for at least a couple of years the IVF fertility concept for our members, and which all of us are for it. I hope that your position, Glenn, is for it, since the board is for this particular item. If it goes out of committee after the May 14th forecast, and it says that yes, we should do this, would that money be have a budget line item for OEB for us to move forward with that concept, or is it a different department that oversees? Otherwise, I'm happy to go testify.
What would happen would be since it's actually other funds limitation, I won't go in, if that added limitation, the budget limitation was approved, they would include it as part of the 25-27 budget. And so that would give PEB and OEB the capability to spend that money out of our budget and really move forward with that. It would create some issues with meeting the 3.4%, because it is very significant in regards to 1.3 for MOTA and 0.4 for Kaiser. So, and I don't know. I mean, it could create some issues with that. We'd have to work with Mercer and the carriers on that. In regards to position from a PEB and OEB standpoint, we don't take any positions on bills. Since we are part of the executive, we're not permitted to take a position on a bill. That actually is up to the governor.
Enrique, you still have your hand up, or you got another question?
Oh, no, thank you, appreciate it.
Would it be, I'm asking Glenn now, would it be in the purview of us, not us, you staff, but us as the board, that we ask to consider an amendment to say that that particular increase, if that bill passes, is not used in the calculation of 3.4 for one time, for the first time we implement?
Yeah, that's a good question.
Yeah. Generally what we do, as Glenn said, we have to remain neutral, but we report on the impact to the plans, and we do put that language in our analysis of this would impact the board's ability to meet the 3.4%. But as far as an exception, I'm not sure.
So you don't give them a suggestion or a possible way of handling it if they want to pass it? Because that would be the way out. If I was the legislator, that's what I'm asking you for is, okay, how could we do this and still make it work?
Yeah, our LFO, our Legislative Fiscal Office requires us to report the actual impact. So as far as an exception, I just, don't.
Yeah, not
when
from
we
you
end
staff,
up with
because
them-
you staff
yeah.
work for the government, but us board people can talk like
Oh,
that.
yeah,
right?
the board, you all can advocate outside of your board role. Yeah.
Okay.
But yeah, we end up with unfunded mandates because that's what it essentially would be, is something for the board to cover that has a fiscal impact in it. But
I'm just all for
takes some
giving legislators an option. Like, here, think about it like this, right? Yeah, you can't, but I can, right?
So what happens sometimes is, with bills, and we actually have a couple this year, is they will exempt PEB and OEB from a piece of legislation. Say there's a new benefit, mainly because that way it would avoid going to Ways and Means on that. And it wouldn't lead to any cost. So we will get, sometimes they'll say, we're going to exempt PEB and OEB as a way to get around that.
Yeah.
Eventually we have things that we talk about that we would like to do if we could just get it past the 3.4 one time. Right.
Mm-hmm.
And we could throw it in there and just on that specific topic. Right. Maybe we could get some buy-in. But anyhow, I'm just throwing that down as a thought.
Sure.
And everybody to think about. Right.
Yeah. And to be honest, the legislators don't, what they're looking at is in regards to the budgetary cost, the added budgetary limitation. We do, as Ali said, we do indicate, hey, this is going to make it harder for us reaching the 3.4%. And there's some really, legislators who do take that into account, but there's others that, say, well, then PEB and OEB have to cover it or however, so it's what I'm trying to say is it's not kind of always a legislative roadblock to stopping the passage of a bill.
Yeah. Okay. Any other questions? Legislative update? Seeing no hands, I'll ask Rose if there was any public comments submitted.
No public comment.
In that case, I'll open up the floor for board members on any specific topic of business you wish to make a final statement on. Anybody have anything they want to shout out about?
Enjoy the sun.
My wall thing says 87 degrees in Aurora, Oregon. So, right. All right. Seeing no hands, next meeting, first Tuesday in June. For those who want to attend the Innovation Work Group, when that we'll send out an email on that. Otherwise, thanks everybody. I appreciate it. See you next June. See you in a month.
Thanks so much.
Bye.
Thank you.